And there's a couple of comments actually from the previous lectures that I thought that they are very interesting, and most of them was for the first speaker. There is a lot of Egyptian program directors in the United States. They are not many, but they are not quite a few either. And we will all be willing to help if you want to help with that infectious diseases fellowship. I have an experience doing this now for over 15 years, so I'll be happy to help with that. The second part is, I think we should include a lecture by the name of the top 10 reasons why I became an infectious diseases physician, because it's very important to be able to tell why people choose this as a career path. And for people who did this in the United States during the time I started, which was 1990, there is no money in it. Infectious diseases has no money. So one of the people that go in infectious diseases are not looking to do procedures, and I think that's one of the impediments that we have here in Egypt. And I have long discussions before with multiple people, especially deans of medical schools here in the country. The third thing is also that infectious disease has to be open to everybody who does internal medicine. Other than this, your pool is very, very limited, and you are not going to get as many people. In the United States, actually, infectious diseases is suffering from people going into it. There is not as many as people are going into cardiology and other stuff. So. And the biggest reason is there's lack of foreign medical graduates who want to do infectious diseases. I did infectious diseases because I became interested when I did microbiology and parasitology in Egypt. And then I went there. People like me are shrinking because everybody are going into cardiology and pulmonary critical care. And finally, what I would like also to say is antibiotic stewardship is not an infectious diseases concept, okay? It's a hospital service. And this hospital service are compromised of many people. It's a multidisciplinary deal. And people became interested in antibiotic stewardship very long time ago. I trained into it as even a fellow, but at the time we were mainly interested in restricted drugs. There were a very long list in every hospital formulary that only had to be approved by infectious diseases, otherwise you cannot get them. And I started this way, and then started doing it as a job and a hospital service, separate from what I do as an infectious diseases consultant, where I go and see the patients. This is mainly reviewing what you know about the patient and the information about them without seeing them. And that's a big difference between us and between an infectious diseases consultation service. And since I do not see them, I don't lay eye on them, I only review the record and look at the microbiology, how they presented, I review the x-rays, I review a lot of other things. That's why my opinion is not mandatory, okay? So it's mainly a suggestion. You are better off basically if you listen to it, but if you don't, it's entirely up to you. Having said that, the most important thing is communication. You have to have very good communication skills. A physician to a physician phone call works much better than just if I leave a note on the chart, which I actually do it for documentation. So for people who are not familiar with antibiotic stewardship, it's multidisciplinary things that we promote the appropriate selection of the antibiotic, the dosing, and the duration of antimicrobial therapy. And this way, if you do it this way, you are cutting a lot of expense, decreasing the length of hospital stay, and decreasing the toxicity of antimicrobials. So the primary goal, again, is to make sure that the patient is getting better, but the side effects are much smaller. So if you keep somebody on vancomycin for 2 weeks and he does not have staph infection, you did far more harm, not only in the cost of the drug and monitoring of the drug and the labs you have to do, but also increase the length of the stay, increase the cost of the hospital, and you might give this patient a renal failure, correct, with these drugs. So the unintended consequences are very high. It's like somebody you think they have a DVT, you give them heparin and you leave them on it, for a few days, they bleed. It turned out that they didn't have a DVT. All what you did is more harm, which we are taught not to do it. I've been trying to get our hospital before 2016. It took me 3 years to convince my hospital to have a service that we get paid for it. Okay? The only reason they listened, it became a law. It became a state law in the state of California. Every hospital have to have an antibiotic stewardship program. So legislation is very important. And if I did not have the state adopting a law in 2015 that every hospital has to have an antibiotic stewardship, I doubt I would have been successful, not only in doing it in my hospital, but having it citywide. Because after my hospital, another sister hospital adopted it, a private hospital adopted it, and the VA adopted it. So all of a sudden, it went from only a hospital of about 750 beds to all the hospitals in the city, which is about another 1,000 beds. So you are looking at about 1,700 citywide program. Where is the? Okay. In designing the antibiotic stewardship, I didn't just go, they took me for my word for it, the administration. We had to do a business plan actually and show them it's not only what we are proposing to do, what are the results we are going to monitor, how much it's going to cost the hospital, but moreover, anything else, how much money I'm going to save the hospital in the first year and a half or 2 years. So on a budget of about $600,000, it's not cheap, $600,000, okay, that we used to fund the antibiotic infectious diseases physicians and the infectious disease pharmacist. You have to have a very good commitment from the pharmacy and some clerical support and doing some programmings of the computers. It costs about $600,000 in the first 18 months. We saved them $2.4 million, which is a huge return on investment, at least in the US. So what did we promise for them to do? We targeted certain drugs, antibiotics that are broad spectrum, that are expensive. And we told them we are going to lower the use of these drugs. So what we selected was biptazobactam, which is Zosyn, I don't know the name here in Egypt, meropenem, daptomycin, liposomal amphotericin, voriconazole, and flucytosine. And I can talk, in more detail later how we did this. We were very hugely assisted by having a medical record that's electronized. So we have an EPIC program, which is basically a depository for what's going on about the patient, not only in the hospital, but if they had admissions in other hospitals in the city or other cities or even state, we can access their records. And we know what they have been exposed to, what antibiotics they have been used in them before. And we have all the microbiology data about the patients and all radiology. If you don't have quick microbiology identification, you cannot really have a very robust antibiotic stewardship. You cannot rely only on culture techniques that it takes about a week or two for you to have a result back. To have a successful program, you need to have some results in 1 to 2 or 3 days at most. So you can go to the people and say, okay, fine, you were worried about X bug or X organism. It's not there, stop the tazocin or stop the biptazobactam. You don't have any mold infection, stop the liposomal amphotericin. If you don't have rapid diagnostics, which is, I think we listened to a lecture about this, you really cannot have a robust program because any reasonable physician cannot argue my cultures are not back yet. So reliance on culture is still there, but you have to have things to help you the diagnosis rapidly, whether it's a PCR, MALDI-TOF, or another forms of fast microbiology. Big part of our policy also is to switch people from IV to PO. So to give you an example, quinolones, most of the quinolones are almost 100% bioavailable. So if you're giving somebody levofloxacin, okay, if you give him IV, and let's assume that those IVs about $10, it's more expensive than that, and you calculate how much it costs in the tubing and the bags and saline and the nurse's time and the pharmacist's time, this is much higher than only $10. Probably it's more, add another $10 for the tubing and the times and everything else. That's about $20. One pill of levofloxacin cost, it's generic, it can cost less than $1. Okay, so from $20 to $1. If the drug is 100% bioavailable, why shouldn't we use it? So you have to have, instead of IV, which is more expensive, and you can save a lot of money, you can send the patient home faster, and you work quite as well, correct? And the organism does not know the route you are administering the antibiotic by. So if you give them something oral that can send them home, and there's a lot of data not only in diseases like pneumonia or UTIs or similar things, but there's even data nowadays in bacteremias and people with serious infections that you can give some of the antibiotic orally or give it IV first till they are stable, switch to oral and send them home. It decreases a lot of the complications from the IV itself. So examples of the inappropriate antibiotic therapy that physicians do, or all of us do. Use antibiotic agents for treatment of syndromes that are not caused by bacteria. A lot of what we see, for example, for acute exacerbation of chronic bronchitis, that's predominantly viral. Giving them antibiotics, especially without criteria to indicate bacterial infections, is going to be a waste of the drug. Most of the colds, most of the acute bronchitis, sore throats are not really caused by bacteria, so don't treat it. Anybody here who works in the United States know that one of the most dreaded consults, or people we really don't like this consult, come and see the patient for fever. Fever does not only have to be an ID. A lot of rheumatologic diseases and cancers and other things can cause fever or elevated white count, correct? Not only infections cause elevation of white count, so not go ahead and start the antibiotics, you have one of these parameters is present without any other manifestation of infection. And there's a new term I've seen circulating in the United States is mainly leukocytosis prophylaxis. This is an indication for use of antibiotics. Please don't do this. Treatment for culture results that reflect colonization or contamination rather than infection. The biggest part is UTI diagnosis. UTI is a clinical diagnosis, not a microbiologic diagnosis. The patient have to have burning sensation of urination, foul-smelling urine, fevers, maybe high white count, maybe CVA tenderness. But if the patient come in and because routinely we obtain UAs from them, and it indicates infection, you have high nitrite, leukoesterase, some white cells, you are going to put them on antibiotics. That's not indication. The main indication nowadays for treatment of UTI that are asymptomatic, there is no symptoms, are people who have going to have a urologic procedure that you are going through the bladder, either to do a biopsy or a cystoscopy. These are the ones that you need to sterilize the urine before, and very few early cases of people who have kidney transplant. You can give them in the first few months for asymptomatic bacteriuria and for pregnant females. Other than these three indications, if the person does not have any symptoms, you should not treat them. Even elderly patients that are coming to present with burning sensation, not all the time they have an infection, and in females can be estrogen deficiency. It is just not indicated. You can save a lot of money and impact resistance in any hospital by just only targeting UTI patients, that you should not give antibiotics to all of them. And giving antibiotics that are too broad spectrum, even when you get the culture, you do not de-escalate, correct? You are covering for gram-positives and gram-negatives. You are giving tazocine and vancomycin. If the MRSA is not there, you don't need the vancomycin. MRSA grows very quickly in the lab. You should have the results very quickly. And if you have any of the PCRs that can detect MRSA, you can have your results in 15 minutes after you identify the organism. After you identify a coagulase positive staph, If you run one of the PCRs, it can tell you it's MRSA or MSSA, or if it's even present. There is data in pneumonia that in people who are not colonized the nasal screen with MRSA, if it's negative, you can safely stop anti-staph drugs because they just do not happen. Okay, so you can stop it because you know the culture most likely will be negative after that. Okay, prescription of antibiotic therapy for treatment or prophylaxis that's longer than necessary. And what's necessary nowadays for community-acquired pneumonia, there's data with 3 to 5 days of treatment with antibiotics. Intra-abdominal infection is 5 days, especially after control. If it's surgical, it's 5 days after control of the course. Most of the bacteremias is 7 days, with the exception of gram-positives and some of the serious gram-negatives. And especially continuing a treatment after you have an organism. One of the common things, especially in cancer patients, people are worried or are not sure, but why obtain the culture if you are not willing to act on the results? Correct? The only thing that's growing is staph. Why do you need to cover gram-negatives? The patient is improving, they are different because I don't know why they got, I don't know if we missed something. You know, that's why, again, having a good microbiology lab is extremely important. Giving too high or 2 doses of antibiotics, pneumonia, ceftriaxone 1 gram a day, most of the time, correct? If you have bacteremia, it's 2 grams. If you have meningitis, 2 grams twice a day. The problem is people will look at some of the textbooks or the pocket books, and it says, for mild to moderate infection, 1 gram. For severe infection is 2 grams. Everybody in the hospital has a severe infection, so it's 2 grams. Okay, we need better understanding of the PK and PD, pharmacokinetics and pharmacodynamics of antibiotics, because that's how we do our dosing, and we have to convince people that you really do not need this much high dose of vancomycin. If your area under curve above MIC is over 400, that's what we are shooting for. It should work beautifully, okay? And you have the pharmacist helping you to do this. And treatment of processes that do not provide with agents that does not give any activity against causative agent. Like I've seen people writing patient with ertapenem that covers Pseudomonas continue ertapenem. It doesn't. It does not cover the organism. So some of our part also as an infection, as antibiotic stewardships, is we go and tell people what you are covering with is not active, or what you are covering with is not adequate, and we recommend escalation, not de-escalation. So not all of the time I'm calling people and telling them you need to stop the antibiotic, okay, or narrow the spectrum. Sometimes you can then tell them you need to increase the spectrum. What are the major objectives to achieve best clinical outcome? Minimize toxicity without a side effect, limit the selective pressure on the bacteria population, and also decrease the excessive cost attributable to suboptimal antimicrobial care. Dr. Umayma first said that most important thing about infectious diseases consultation is it gives you better outcomes. It treats the organism. It has been shown in many cases of bacteremia and people with febrile neutropenia, in a lot of other cases, endocarditis. Decreases length of hospital stay. People do better with an infectious disease consultation, not without one. Whether they listen to me or listen to an infectious disease consultant that goes and see the patient afterward, that's the important thing. So what are has been associated with, like I said, 23% to 36% reduction in all the antibiotic use in the hospital, reduced rates of antimicrobial resistance with Pseudomonas and Staph aureus, reduced incidence of adverse events, toxicity and C. difficile, and significant reduction in pharmacy expenditure. And we have met all of these objectives in the first 3 years of our program now. So in terms, we already decreased antibiotic use significantly in some of the drugs. We almost totally, meropenem, we decreased the dose by almost 75% in our hospital after we implemented a certain questionnaire that people, before they prescribed meropenem, they have to go under and answer these questions. And if you don't answer them, it does not fit. We deny you people using meropenem. Reduced rate of antimicrobial resistance. When we started, we had 100% MRSA in our hospital. Now we are almost down to 50%. This is not only attributable to us, there's some epidemiologic shift in the United States, but this has been magnified in our hospital. We have far reduced rates of C. difficile after almost 4 years of very high levels in our hospital. Now it's within the national guidelines, and significant reduction in pharmacy expenditure. I just mentioned the money about this. So how we do this? Okay, it's not only me reviewing things. Most formulary restrictions in broad spectrum antibiotics, you have to get an ID approval. It doesn't be a consult. Audit that's always going on. We review the charts. I get a list of everybody who's antibiotic in any of our hospitals every single day. We have a computer program that will review it and pick certain individuals that are on complicated regimens or multi-drug regimens, or people who have a single drug but it's restricted. They get pulled out for review by me, other physicians, and the pharmacist. And we call the people right away, the people who prescribe the medication. What other strategies that should be in place is education. I cannot go to tell a person, you need to do this and this and this without telling them a reason why am I doing this. So we usually have lectures for all the medical staff, and it has to be repeated over and over because retention and lecturing is very, very small. So we need to repeat this. We have very wide use of the guidelines and antibiotic forms, which is basically if you are having a disease entity like pneumonia, here are the drugs we recommend, here is the way of cultures we would like to do, and this is going to be reviewed within 48 hours by our team. Dose optimization. That's basically all based on pharmacokinetics and pharmacodynamics of antibiotics. Switch from IV to oral, not only fluoroquinolones. Fluconazole is 100%, voriconazole is 100%, flagyl, doxycycline, a whole list of antibiotics can be given orally. And if the gut is working, we usually tell people to switch to using oral. If the patient does not have severe nausea, vomiting, throwing up, or having very rapid transit time diarrhea, you can give them oral. And again, we talked about the program assisted decision support. So what are the challenges we have? Initiating any program is really difficult, and having to call physicians and tell them your management is suboptimal, you need to look at it a different way, needs a lot of first-hand knowledge of the people and a lot of cooperation for the ordering physicians to get them to change medication. I cannot go and change their order. Antimicrobial use and resistance are very complex. It's not an easy subject. Most of the non-ID people don't understand it quite well, and it can seem to be very overwhelming. Physicians are very resistant to anything that restricts their autonomy. And, the public has a huge misconceptions about antimicrobial drug. If you are going to the doctor, you have a sore throat, you have some fever, your body aches, you expect to walk away with a prescription for an antibiotic. You end up spending more time with the patient telling them you have a URI, you have a cold, you don't need an antibiotic systemically. It takes much more time doing this than just simply write for a azithromycin back and here it is, go ahead and take it home. So there's a lot of very time. So it's one of these interventions that high intensity and high yield, if it's, if you want to describe it easily in a different way. I'll tell you, the people that give me the hardest time in the hospital are surgeons and ICU, and it's just sometimes it's like, butting heads, but at least if nothing else, I convince them to get an infectious diseases consultation, just to settle that dispute. Does it always work this way? No, because sometimes, again, as consultant, I go and tell people, here is what you need to do, but it's left to them to decide, should I do this or not? The best cooperation I get are from the hospitalists. But if you look at some place like our hospital, hospitalized admits about 80% of all the population of the hospital. I need to have very good relationship with them, and they let me basically do what I want. So, and the most important thing is give them good advice, because if you give them a couple of bad ones, that's all what they are going to remember. They are not going to remember anything good that you've done for them for the past. I try to just basically do things quickly, and I've done it in 20 minutes or so. Any questions, I'll be happy to take them, and you can eat and you can pray.